This is an example of a case where a 74-year-old woman presents to your clinic for the first time following the retirement of her general practitioner. Her medical records show consultations and results of laboratory analysis, but does not appear observation or monitoring her treatment. There is a history of depression, hypertension, bilateral cataracts, surgery, bilateral knee osteoarthritis, a left knee prosthesis, and she had 3 normal deliveries. She's a widow and lives alone. She has 2 children that live outside, and her daughter helps her 2 times per week. Her last medication list include atenolol, 100 milligrams per day, valsartan and hydrochlorothiazide once daily, paracetamol 1 gram up to 3 tablets per day, zopiclone 7.5 milligrams at bed, bromazepam, a quarter of a tablet in the morning and half a tablet in the evening, and haloperidol at night. You query the patient about haloperidol since you do not understand the indication, and she says that it's probably for her sleep disorder. So you decide to stop bromazepam and haloperidol. In the second visit, she can no longer sleep at night because she sees persons in her apartment. She thinks she might be going crazy and is too frightened to explain her symptoms to her daughter. You decide to organize monitoring at home to better assess her situation. During your home visit, you find that the home is clean and tidy. You call her daughter, and her suspects memory loss and reports some falls in the last year, and informs you that she is unable to take her mother to house. You decide to organize a geriatric psychiatric follow-up and take an appointment with psychiatry. 2 months later, psychiatrist has established a neuroleptic treatment, but there has been no medical social assessment of the patient. You take an appointment for geriatric assessment, which takes place in 4 months. 3 months later, her daughter informs you that her mother suffered many falls and she is no longer taking neuroleptics because of intolerance. The patient hands you referral for a geriatrician, but does not understand the benefit of the consultation. An individual care plan is urgently needed. Urgent issues that need to be addressed include stabilizing the patient's mental status in addressing her hallucinations and depressive symptoms, and to better define her diagnosis, whether her psychiatric condition is neurological or psychiatric. You doubt the associated cognitive impairment and consider cognitive assessment once psychiatric condition is stabilized. Her falls must be addressed, and iatrogenic effects of the drugs must be considered, and we must monitor the compliance of her medication, and we must address her specific isolation at home. So an integrated care plan would look something like this, where we have the problems addressed from 1 to 6, with psychiatric being the first priority, medications, patient understanding her situation, cognitive effects must be addressed, the functional decline and falls must be addressed, isolation and security, specific objectives are made, responsible people are addressed, and criteria for achieving each individual goal is described. And goals are set as short-term and long-term, depending on the priority of each condition. And you should be the orchestrator of all of these priorities. The summary of the lecture shows that the geriatric syndromes are not part of the traditional disease model, that there is significant interest in enabling family caregivers to sustain their roles and maintain the elderly in the community. There is lack of identified geriatric availability for care of the elderly in Saudi Arabia, and an individual care plan is encouraged to support for multidisciplinary teams in a non-hierarchical framework for cooperation. The take-home message of today's lecture includes that the disease management model is different in the elderly, so care management model should be adapted specifically for each patient. Managing the emotional and psychological stress is needed in order to reduce negative effects of burden of family caregivers. Care of the elderly need an integrated network of service, and an individualized care plan is imperative to improve coordination between local health and social stakeholders for a more efficient care pathway. Thank you very much for listening.